Hello, my name is John Pouliot, and I'm a consultant pharmacist with QSource. Thank you for joining me today for this short video where we'll be discussing anticoagulation use in long-term care. Our objectives for today are to review common anticoagulants and their use in patient care, evaluate some of the adverse effects that are associated with anticoagulants with a focus on this particular patient population, and summarize some strategies for decreasing the risk of adverse effects of anticoagulants. Before we get started on the specific anticoagulants, I think it's important to kind of understand what kind of medications we're talking about. Anticoagulants are often referred to as blood thinners, and it is true that they, in a sense, thin the blood and make it less possible for clots to form. There are different medications that do this, so this is a subset of medications that cause the blood to become more thin and less likely to clot. And we use anticoagulants in very specific patient care scenarios to either decrease the risk of a clot forming, or in patients that have been diagnosed with a clot being formed, to give the body a chance to clear that clot without it growing or propagating. The two most common indications that we use anticoagulants for are atrial fibrillation and venous thromboembolism. Atrial fibrillation is an abnormal heart rhythm that causes an increased risk of a blood clot forming in the heart, and therefore that clot can cause a possible stroke. And so the heart is not allowed to pump synchronously, and so the clot can form, and if that clot ends up out of the heart, it can go up into the brain and cause a possible stroke. And so patients that have this particular type of heart rhythm called atrial fibrillation are at significant risk for stroke, and so they will receive full-dose anticoagulants. Venous thromboembolism is a little bit more clear in the use of anticoagulants, and this is when a clot has actually formed. So there's two subcategories of venous thromboembolism: of deep vein thrombosis, which is a clot that forms in the lower leg, typically in a large vein or deep vein, or a pulmonary embolism, where part of that clot breaks off from the leg and goes up into the lung and then causes pulmonary symptoms. And so venous thromboembolism is the big category of this disease state, and then it's broken down into DVT, or deep vein thrombosis, or PE, pulmonary embolism. And sometimes patients will present with both. So they'll have a deep vein thrombosis, and part or all of that clot goes up into the lung and causes a pulmonary embolism. It's important to note that sometimes pulmonary embolism doesn't occur and they just have a deep vein thrombosis. These are two separate conditions that are related to each other. One important thing to think about when we think about this particular class of medications is the difference between anticoagulants, which is our focus, and antiplatelets. Anticoagulants work on a specific part of the blood. Specifically, it's called the clotting factor cascade. So it's proteins that are floating around in our blood that will be activated to create a clot when it's necessary. And so sometimes we have pathology of disease that causes the clot to occur outside of the natural function of these clotting factors. So anticoagulants are going to antagonize or stop parts of this clotting factor cascade. They're not going to work on the platelets. Platelets are a separate kind of mechanism. They're used primarily in atrial fibrillation and VTE, as we just went over. And anticoagulants tend to have a higher bleeding risk. So they're kind of the most common medications associated with bleeding that we have on the market. Antiplatelets, on the other hand, are primarily focused on platelets and platelet function. Now, the clotting factor cascade and platelets do have some interaction in the formation of a clot, but these are two separate kind of mechanisms, ways that these medications work. Antiplatelets are often used in coronary disease, atherosclerosis, post-heart attack, and then in patients that have had a stroke. They tend to cause less bleeding, especially in comparison to anticoagulants, but they often get lumped in together with anticoagulants. So as we're talking about anticoagulants, it's important for us to make sure that we're talking about the right group of medications. Common antiplatelets would be aspirin and Plavix, or clopidogrel. The other consideration for anticoagulants is the idea of treating or using treatment dose anticoagulation versus prophylaxis. And so the idea of prophylaxis is preventing a blood clot in a high-risk patient. So these are in the hospital setting. We often will use a low-dose anticoagulant to prevent somebody from developing a deep vein thrombosis in the inpatient setting. And sometimes you may see this in long-term care settings where patients that are bedbound, they're at increased risk of a blood clot formation. And so sometimes you'll see low doses of anticoagulation used in these patients. So typically speaking, for prophylaxis, we're going to use a lower dose, or we're going to use a different route of administration. So we'll see that when we talk about the specific medications. This is in comparison to full treatment dose. And so treatment dose anticoagulation is going to be the higher of the two doses, so normal doses. We either have a blood clot that's formed, or they're at increased risk of stroke. So those two indications that I talked about before. Full doses, and this is going to be associated with much higher risk of bleeding than we see with the lower dosing of with prophylaxis. When we think about common anticoagulants, I tried to keep the list as short as possible. There actually are not any additional oral anticoagulants. Those are the 5 that we have on the market. But injectables, there are some other injectable anticoagulants that just aren't applicable to the long-term care setting. So they're much more inpatient hospitalization type medications. But the 3 that you may see, probably not listed in order of frequency, but just, in order of the classes of medication, would be unfractionated heparin. Unfractionated heparin is used in the inpatient setting and can be given as a treatment dose. So this is one medication that has a different administration based on whether we're going to give it for treatment versus prophylaxis. So when we're treating somebody with heparin, we're going to give full dose heparin. We're going to give it as a continuous infusion, intravenous infusion. Whereas heparin for DVT prophylaxis or VTE prophylaxis is given as a subcutaneous injection every 8 hours. Lovenox can be used as either a treatment or a prophylaxis at different doses. And then a much less commonly used medication, but something that could be seen in the long-term care setting, is a Rixtra or fondaparinux. It's important to note that these injectable anticoagulants are really all in the same class of medication. They have a very similar mechanism of action, but there are differences between the medications that confer benefits and so forth. In our oral anticoagulants, we have 5 oral anticoagulants. There's one that kind of sticks out as something that's been around for a really long time, and that's Coumadin or warfarin. But what we're seeing in practice, and certainly I'm sure you're seeing in your patient populations, is a movement away from using warfarin and toward using these new medications called DOACs, direct oral anticoagulants. So the 4 that we see here are Eliquis, Pradaxa, Savaysa, and Xarelto. Those are the 4 newer agents. And I say newer probably since 2010, 2011, they've been commonly used. So historically, warfarin was the standard of care, but these newer anticoagulants in this class that I mentioned, direct oral anticoagulants or DOACs, they've largely replaced the use of warfarin. And when they studied these medications against warfarin to get them approved by the FDA, they saw that they were more effective, generally speaking. They had fewer adverse effects and certainly less bleeding than we see with warfarin. There were significantly fewer drug interactions. And one of the big things is that they don't need to be monitored. So warfarin requires frequent monitoring of blood concentrations and also the INR to make sure that warfarin is at a therapeutic level. And these new agents don't require that. And so they offer a pretty substantial advantage to warfarin in that they're better from an efficacy standpoint. So they're more effective. They have less bleeding and less other side effects. Warfarin is associated with significant amounts of drug interactions, food interactions, and we avoid most of that with our new oral anticoagulants. The need for monitoring that is present for warfarin is absent with these newer agents. So you're seeing, I'm sure, over the last 5 to 10 years, a movement away from warfarin and towards these newer agents. When we think about anticoagulant therapy, especially in the long-term care population, as patients age, the risk-benefit kind of weighing changes. And so we always want to be asking the question, and this is the number one thing I hope you take away from this video, is that when we're thinking about anticoagulant use, it's incredibly important for us to continually be asking what the risk and benefits are for our particular patient. knowing that as patients age, the risk and benefits are going to change, especially for anticoagulation. So in a younger, healthy patient with atrial fibrillation, the risk of bleeding is much lower than the risk of clotting. But as patients age and they increase their falls risk, they increase other chronic conditions, the risk of bleeding might at some point outweigh the risk that is associated with their disease state. And so thinking about this risk benefit is going to be really important. There are some ways that we can evaluate risk and benefit. One of the ways is to determine if the patient is at high risk of clotting. With atrial fibrillation, we can use this score called the CHA2DS2-VASc score. It pretty much gives points for different disease states that patients may have. So as a patient gets above 75, they get points. And so you add all the points up based on the patient's past medical history. They have a CHA2DS2-VASc score. The higher the score, the higher the risk is for clotting. And so that would help us determine if there's benefit to using an anticoagulant if they have a really high CHA2DS2-VASc score. On the opposite side, we also want to determine if they're high risk of bleeding, especially the number one bleeding event that we're worried about is intracranial bleeding, so bleeding in the brain, because that can be pretty catastrophic for anybody, but certainly your patient population. And one of the scores that we can use in this situation is the HAS-BLED score. And so it's going to help us determine whether the patient has some different clinical characteristics and how high their risk is for bleeding. And then a provider is going to have to sit down and say, okay, I think that the risk of bleeding is higher than the risk of clotting, so we're not going to use anticoagulation, or vice versa. Their risk of clotting is a lot higher than their risk of bleeding. Let's think about anticoagulation in this patient. And so I've kind of given this idea that the main side effect of anticoagulants is going to be bleeding. It can occur at any dose, but it's usually at a higher risk of occurring when the patient is receiving treatment doses of anticoagulation. There are some medication-specific side effects to think about. So injectable medications that are given subcutaneously are associated with injection site reaction, bruising, hematomas at the site of injection. And so that's specific to all three of our common injectable anticoagulants. Heparin and Lovenox can induce something called heparin-induced thrombocytopenia. And this is where the patient has an immune reaction that causes them to consume their platelets, and their platelet count goes down really low. It's not as common with prophylaxis dosing. It's less common with Lovenox than it is with heparin, but it can occur and does warrant some monitoring of platelets, especially when the therapy is initiated. Pradaxa, which is one of our direct oral anticoagulants, has a higher incidence of indigestion. It's associated with the salt that's used in the formation of the medication itself. And then the warfarin is also associated with a very rare side effect of skin necrosis. But I want you to kind of take away the biggest thing that we're worried about with anticoagulants is bleeding. So how do we try to prevent this bleeding? The first thing is to ensure medication appropriateness. And how do we ensure that? By going through that risk-benefit assessment on a regular basis, not every single day, but certainly if an event occurs, certainly if a patient gets hospitalized, if something occurs that would make us say, hey, time out, let's reassess what our goals are. So maybe the patient is moving into a comfort care or hospice scenario. That would be a good opportunity to look at all the medications, but certainly to look at anticoagulation. But just generally speaking, making sure that you're on a fairly regular basis making a risk-benefit assessment of anticoagulant use. We want to make sure that we're evaluating dosing and drug interactions and so forth, especially with warfarin. But with all of our medication, we want to think about patients with kidney disease or liver disease and making sure our dosing is appropriate. And as patients, especially long-term care patients, as they collect disease states, as they age, they're going to be at increased risk for accumulating medication. And so it's important to make sure that dosing and monitoring is very appropriate. You want to establish clear monitoring plans. So that might be lab monitoring, but it might also be monitoring the patient's cognition, monitoring the patient's falls risk and things like that. And then one of the biggest things that is fairly familiar to you all in long-term care is falls risk and implementing fall prevention strategies. So to kind of take this point a little bit further, I developed a case example that I thought we could walk through quickly. EW is a 76-year-old female that presents for admission to your facility. She has a past medical history of Parkinson's disease, atrial fibrillation, hypertension, hypothyroid, history of falls, dementia, and general anxiety disorder. Her medication list is as follows. She's got carbidopa-levodopa for Parkinson's, levothyroxine for her thyroid, lisinopril, lorazepam, memantine, metoprolol, pramipexole, quetiapine, sertraline, and then she's on warfarin for her atrial fibrillation. So some considerations with this particular patient. This is a fairly typical patient with typical disease states that you would see in a long-term care patient population. One of the things is to evaluate the risk and benefit of continuing the anticoagulant. Sometimes providers say this patient is falling a lot. If they have one fall where they hit their head and they have an intracranial hemorrhage, this could be a catastrophic thing for the patient that could significantly reduce their quality of life versus the risk that's associated with a possible ischemic stroke. We would want to do a polypharmacy evaluation. There was several medications on the patient's list that could alter their mentation, and certainly some medications that are on their list that don't have a proper diagnosis. So we'd want to walk through that. If we can decide to continue the anticoagulation after doing this risk benefit, it might be good to consider changing to a direct oral anticoagulant. We have decreased side effects, decreased drug interactions, decreased risk of bleeding. So a lot of benefits to a DOAC in this case. So it would be good to try to talk about why the patient's on warfarin instead of a DOAC. Is it a good reason, or is it a reason that we could maybe reconsider that choice? Like I mentioned, the polypharmacy psychotropic evaluation, those medications will increase the risk of falls. And so trying to evaluate and decrease their use as much as possible is going to be important. And then developing a good monitoring plan for this patient that's going to include laboratory monitoring, but also monitoring for falls and falls risks and so forth. How do we manage patients if they have a bleeding event? If a patient falls, especially if they are unattended or it's an unwitnessed fall, they need to be evaluated, because if they are going to be at increased risk for a traumatic brain bleed. And so we want to try to make sure we're staying on top of that. And the sooner that we can get that person identified as having had that, the better their outcomes are. Outcomes are not great when people bleed into their brains, but certainly time is of the essence in those particular cases. Other bleeding should be treated with urgency, and it's important to note that patients that are on anticoagulants are going to bleed more and potentially for longer than those that are not on anticoagulants. And so it's important to be thoughtful about that. And then after recovery from the bleeding event, it's important that we have a reassessment kind of discussion about the risk and benefit of anticoagulation use. So in summary, anticoagulants are commonly used in patients to prevent stroke or to treat blood clots. Anticoagulants are different than antiplatelets and can be dosed for both prophylaxis or treatment. Bleeding is going to be the by far most common adverse effect of anticoagulants, and something that we want to be very thoughtful about when we're using them. We want to implement strategies to minimize those adverse effects, including ensuring appropriateness, monitoring, preventing falls, doing some education to staff, and then making sure that we are dosing the medication appropriately. And then if the patient does have a bleeding event, they should be evaluated as soon as possible. I hope this short video was helpful for you. My contact information here, and we would be happy to partner with you in any way we can to try to help improve your preparedness for and use of anticoagulants in your facility. Thank you so much.